Okay, everybody. So, in today's video, we are going to study common presenting problems from Family Medicine Toronto Notes. So, if we look at this common presenting complaint, which is abdominal pain, which will be covered from gastroenterology G4, general surgery GS4, and then emergency medicine ER 18. So, these are the page numbers that you have to go and look into abdominal pain as well. So, once you cover from 4 different chapters, then only abdominal pain would be covered. Let's go and look at the MCC objectives. So if you look into the MCC objectives, you'll see there's one whole entire objectives of abdominal pain, which says chronic abdominal pain, acute abdominal pain in children, and then anorectal pain. So if we click on the chronic abdominal pain, so the conditions they want you to know in upper abdominal region is malignancy, peptic ulcer disease, biliary disease, pancreatic hepatic disease, and referred cardiothoracic pain. Lower abdominal pain, they want you to consider IBD, diverticular disease, IBS, malignancy, genitourinary disease like dysmenorrhea, benign and malignant tumors, other causes like food allergies, intolerance, celiac disease, constipation, musculoskeletal, and functional. And now here they want you to know the clinical findings, and those derive from history and appropriate examination. So history and examination findings, lab investigations, advanced imaging, endoscopic evaluations, a management plan, non-pharmacological, pharmacological, medical and surgical. Long-term follow-up is required due to risk of later complications, recognition of possible underlying psychosocial issue leading to abdominal pain, spousal abuse or anxiety. So you do have to consider in chronic abdominal pain, anxiety and spousal abuse as well. So this is important for QE1. All right. Going back, so this is acute chronic abdominal pain. Now, acute abdominal pain would be the causes would be biliary tract disease, pancreatitis, peptic ulcer, GERD, hepatitis, splenic infarction, cardiothoracic pain, MSK pain, appendicitis, lymphadenitis, diverticulitis, incarcerated hernia, PID, ectopic pregnancy, ovarian torsions or ruptured cyst, UTI, renal colic, IBD, bowel obstruction, and diffuse pain causes are generalized peritonitis, ruptured abdominal aortic aneurysm, ischemic bowel disease, gastroenteritis, initial and acute presentation of chronic pain. So history you have to check the onset, frequency, duration, location, radiation, quality, and severity of pain, aggravating and alleviating factors, results of the abdominal examination, signs of peritonitis, results of rectal genitourinary examination, appropriate investigations, diagnostic imaging, and management plan like emergency surgical procedures, medical care, management plan for non-emergency conditions, and specialized care and further investigation. So these are the acute abdominal pain conditions they want you to know in children. So this is specifically going to be covered in general surgery and pediatrics. So this is not something that would be covered in family medicine. So fissures, these are all the GS condition, dermatitis, sexually transmitted. So these conditions are basically the anorectal pain. So we're specifically going to just look at chronic abdominal pain, acute pain, and then pain in children is will be covered in pediatrics. So now coming back to abdominal pain. So what is the epidemiology? 20% of individuals have experienced abdominal pain within the last 6 to 12 months, 90% resolve within 2 to 3 weeks. Only 10% are referred to specialists. For those, less than 10% admitted to hospital. Causes: most common diagnosis in family medicine at 28% is non-specific abdominal pain, which has no identifiable cause and is usually self-limited. GI disorders like peptic ulcer disease very common. Pancreatitis, IBD, appendicitis, gastroenteritis, IBS, diverticular disease, biliary tract. So these are the more common conditions in the family medicine clinic. UTI is one of the most common causes, then renal calculi, gynecological causes like PID, ectopic pregnancy, endometriosis, cardiovascular conditions like coronary artery disease, abdominal aortic aneurysm, bowel ischemia, other causes like DKA, porphyria, hypercalcemia. Medications like NSAID can cause it, alcohol, toxic ingestion, foreign body, and psychogenic. So these are all the causes, out of which the most common like GI causes, urinary causes, gynecological, cardiovascular. So you can divide it systematically. Pathophysiology, type of pain. So there are two types of pain. One is somatic and the other one is visceral. Somatic is the sharp localized pain if it's around the skin. Visceral is a generalized pain and it's a dull pain. Location of the pain. Epigastric is mostly caused by distal esophagus, stomach, proximal duodenum, biliary tract, pancreas, liver. Right upper quadrant pain is specific for biliary, hepatic, and colonic and pulmonary renal. Left quadrant is cardiac, gastric, pancreatic, and renal and vascular. Periumbilical pain is the distal duodenum to proximal 2/3 of the transverse colon. Hypogastric is distal 1/3 of the transverse colon to rectosigmoid region. Right lower quadrant is colonic appendix and gynecological renal causes. Left lower is colonic gynecological renal causes. So you need to have a good concept of the quadrants of the abdomen, and then you have to think like right upper quadrant does have a gallbladder, biliary tract, the liver, then the right lung, and the right kidney. So these are coming under right upper quadrant. Left upper quadrant has cardiac, gastric, and pancreatic and renal. So localize it. For I would suggest you to for you to have a good idea of how you will remember it. I would suggest just go on to Google and abdominal quadrants, so and organs. So you just have a look on the picture and you should be able to remember it. Let's say I'll open this picture up, and once you open this picture up you will see each organ within each quadrant. Where is the picture? So here, so you see this is the good picture that you can take screenshot for, and you can have a look right here in the right upper quadrant. This is right upper quadrant, this is the left upper quadrant, this is the right lower quadrant, and then this is the left lower quadrant. But there is an epigastric region over here where there is stomach, and there is duodenum and pancreas. So you can take a screenshot and just have a clear idea of what is happening in which quadrant and which organs are we gonna think about. Okay, so nothing to really learn by heart, but just to have an idea. And this really helps in clinical setup where let's say patient is coming, doctor, I have pain in this side of my stomach, so you now know as a doctor which organ is at that particular location. So any locations can be because of aneurysm, dissection, ischemia, varicella zoster and virus, muscle strain, hernia, bowel obstruction, peritonitis, and porphyria, and decay. So each one of them have their own characteristic symptoms. Let me tell you, aneurysm would come up with sudden sharp pain radiating to back, let's say, or maybe pancreatitis as well. Dissection, similarly, tearing pain. Ischemia would be somewhat, associated with left upper arm pain or jaw pain, or let's say sudden onset of pain with atrial fibrillation history. Varicella zoster would be in a elderly, let's say female patient, male patient with skin symptoms, burning. Muscle strain would be a history of lifting up something. Hernia would have a history of, let's say, past surgeries or obesity or pressure like symptoms. Bowel obstruction would have a history of constipation or any previous surgeries with multiple surgeries in the past. Peritonitis would have tender abdomen and would give you an erect abdominal X-ray that would show air under the right diaphragm. Porphyria would come up with itchiness, decay, young child with dehydration symptoms and abdominal pain. So moving forward, what investigations would you guided by the finding on the history and physical examination? Let's say I've just discussed few symptoms here. So every diagnosis has its own workup. Let's say if there is a cardiac cause, you would think about ECG first. If it's a biliary cause, you would think about CT scan or an ultrasound or liver function test. If it's a, let's say, pulmonary cause, you would do a CT scan or you would do a X-ray. Renal causes, you would do an X-ray KUB if it's a stone, or you would do urinary test if it's a UTI. So every finding has its, according to the history and physical examination, you would do investigations. But general investigations would be CBC, electrolytes, blood urea nitrogen, creatinine, amylase, lipase. So this is for pancreatitis. And then AST, ALT, ALP, bilirubin, glucose, INR, PTT, toxicology, screen, and beta HCG. Remember, beta HCG is very, very important for a fertile female, young female coming with abdominal pain. Think about pregnancy, ectopic pregnancy first, okay? Now, imaging, chest X-ray, free air under the diaphragm in the setting of perforation in surgical abdomen. Let's say a patient had multiple surgeries or maybe just had a surgery and now is coming up with abdominal pain. So you'll think about chest X-ray to rule out free air under the diaphragm. Abdominal X-ray, KUB, to look for any stones, gas pattern, free air. Abdominal X-ray you'll do for intestinal obstruction, which would show gas pattern. And free air, kidney stones, constipation, ultrasound, renal stone, gallstone disease, gynecological, liver, pancreatitis, appendicitis. CT scan you will do for abdominal aortic aneurysm, appendicitis, non-contrast helical CT. First choice for renal CT. So this is something that you need to remember, that for renal stone you have to do non-contrast helical CT. Okay, other tests, urinary analysis, endoscopy for peptic ulcer disease, gastritis, tumors, and H. pylori testing for urea breath test or serology. H. pylori serology or urea breath test or biopsy. So these are very important, concepts, but honestly, I would tell you, not only this area is covering your entire objective for abdominal pain. This is very incomplete if you're just relying on family medicine abdominal pain. This section, no, you have to go and cover it from G4, from GS4 and ER14. I'll cover the boxes on the right side, and then I'll shift to these specific pages as well. So let me just scroll up. So alcohol abuse was done in the previous video. Now this was also covered. Now here, if pain precedes nausea, vomiting, cause of abdominal pain is most likely require a surgery. So if, let's say, patient is coming in ER, in a family clinic office, what we usually do is, if the patient says I have abdominal pain, the next question is, do you have any other symptoms? Do you have nausea? Do you have vomiting? If the patient says yes, then it is something alarming. We have to think about urgent causes. Abdominal pain red flag: severe pain, signs of shock, peritoneal signs, abdominal distension, pain out of proportion to clinical findings, new onset of pain, change in pain, altered bowel habits in elderly, weight loss, blood per rectum or melena, anemia, subclavicular nodes, family history of serious bowel disease. So these are all the red flags. So if you know a good, let's say, number of red flags, then you will be able to pick up any abdominal pain that is actually serious. Severe pain, shock, peritoneal signs, distension, out of proportion in elderly patient, history of weight loss, blood per rectum. These are red flags related to, let's say, cancer. Weight loss would be in cancer. Bleeding per hour per rectum is because of colon cancer as well. Anemia is one of the cause that you would think about colon cancer as well. Supraclavicular nodes, family history of serious bowel disease. So these are some of the red flags. If patient is more than 50, keep a high index suspicions of abdominal aortic aneurysm. Its presentation may mimic renal colic or diverticulitis. So if a patient is coming to ER or even in a family clinic but with abdominal pain, so keep a high suspicion of abdominal aortic aneurysm, and its presentation is similar to diverticulitis and renal colic. So these are kind of pain, twisting pain, where patient is unbearably, is not able to manage the pain. So this is a twisting pain. And then investigations and treatment according to whatever is required. Now we'll move on to G4 and see what they want you to do in G4. Okay, so let's move on to G4 and see what exactly is covered in abdominal pain. We'll take you from there. Okay, so here is the list: differential diagnosis of common complaints. So you see this is G4. So in G4, this is the list of visualizing test for GI tract. Now here, acute upper abdominal pain. Remember to rule out thoracic causes like MI, pneumonia, dissecting aneurysm. So if the patient, let's say if an elderly patient, 60-year-old diabetic patient coming with epigastric pain, you have to think about MI as well. Pneumonia, patient would have fever, congestive, cough symptoms, but sometimes patient do come up with atypical pneumonia as well. So pneumonia is one of the differentials in abdominal pain, upper abdominal pain, and also dissecting aneurysm. All right, so you see this key around this topic. That means it is one of the MCC objectives. So make sure not to miss anything that is showing this key up on here. Okay. Now, differential diagnosis of common presenting complaints: chronic recurrent abdominal pain. So, if the patient is coming with pain, so what are the inflammatory causes like peptic ulcer disease, biliary colic, IBD, chronic pancreatitis, neoplastic or vascular causes like gastric cancer, bowel obstruction, mesenteric ischemia, sickle cell anemia, toxins like lead poisoning, and other causes like measles, MERS, endometriosis, porphyria, IBS, radiculopathy, diverticular disease, anterior cutaneous nerve entrapment syndrome. Oh, okay. Obscure but treatable causes of abdominal pain: acute intermittent porphyria, hereditary angioedema, familial Mediterranean fever, vasculitis, polyarthritis nodosa. This is one of the vasculitis, familial Mediterranean fever, and these are basically the treatable causes of abdominal pain. All right. So now moving on to the right box here, inflammatory diarrhea. So diarrhea is not something that we are covering today. It's a separate I would say objective. IBD is a common cause of bloody diarrhea. No, this is also covered in there. So dyspepsia, you see this nausea, vomiting with abdominal pain, relieved by vomiting, gastric outlet. So what I would suggest is, if you directly come to this table, this would be difficult for you to cover it. So it's good if you first cover these topics. Let's say you know peptic ulcer disease is one of the cause. The list is given here. Let's say if you want to follow this list, or you want to follow the one in the family medicine chapter, so you can go by either one of them. What you have to do is you need to make a rule out causes. Let's say if a patient is coming up with peptic ulcer disease, the patient would have epigastric pain, would have a reflux symptoms, bad taste in the mouth, nausea, and would not vomit out but will feel nauseous, especially it's specifically related to meal. And it may the nausea or abdominal pain might even get better with having some food. So biliary colic is something the pain is aggravated on the right upper quadrant. It's mostly at the night time after the dinner. IBD would have diarrhea, constipation type symptoms, but it would change with meals. Chronic pancreatitis is something that a patient will have epigastric pain, which may radiate to the back as well. Okay, so this is basically abdominal, um, I would say abdominal pain. So you can differentiate it. Differential diagnosis of common complaints like abdominal pain, diarrhea, chronic diarrhea, constipation, nausea, nausea with abdominal pain or without abdominal pain. If a patient just has nausea without abdominal pain, that there are other causes like migraine, vestibular disease, raised ICP, drugs, uremia. But if the patient is coming with abdominal pain and nausea, then this is gastric outlet obstruction, small bowel obstruction, GERD, gallbladder disease, pancreatitis, MI, hepatitis, infectious gastroenteritis. Okay. Now, moving forward, dysphagia, odynophagia, abdominal distension, common presentation like jaundice, and so no, you don't have to specifically cover this for abdominal pain, but you do have to cover peptic ulcer disease and rest of them. All right. So what we're gonna do now is I have just quickly shown you GS4. Now we'll move on to GS4. I've just showed you G4. Now we're gonna move and see what they want you to know in GS4 as well. So I'm quickly gonna go and look there. Here you go. So this is G4, GS4. Differential diagnosis of common presentation. So acute abdomen, severe abdominal pain out of acute onset, require urgent medical attention. In patient with acute abdominal pain, the first diagnosis that you should consider are those requiring potential urgent surgical interventions, including peritonitis and bowel obstruction. Two most important differential diagnoses for acute abdomen is peritonitis and bowel obstructions. Okay. Now, differential diagnosis of acute abdomen: right upper quadrant or right lower quadrant. For right upper quadrant, I told you before, biliary colic, cholecystitis, cholangitis, CBD. So you need to differentiate between three. Cholecystitis is inflammation of the gallbladder. Cholangitis is the biliary tract inflammation. CBD obstruction is the stone, cholelithiasis, right, and tumor. Hepatitis, including perihepatitis, Fitz-Curtis syndrome, portal vein thrombosis, Budd-Chiari syndrome, hepatic abscess, mass right subphrenic abscess. GI causes like pancreatitis and presentation of gastric, duodenal, and pancreatic pathology, hepatic flexure pathology, and CRC, subcostal incisional hernia, genitourinary nephrolithiasis, pyelonephritis, renal mass, ischemia, and trauma. Cardiopulmonary right lower lobe pneumonia, effusion, empyema, congestive heart failure causing hepatic congestion, and right pleural effusion. MI, pericarditis, pleuritis, and miscellaneous like herpes zoster, trauma, costochondritis. Urgent need for surgical intervention. What is that? Right, subphrenic abscess and cholecystitis and nephrolithiasis. These are three conditions that require urgent surgical intervention. Right lower quadrant pain has appendicitis, Crohn's disease, tuberculosis of ileocecal junction, cecal tumor, intussusception, mesenteric lymphadenitis, cecal diverticulitis, cecal volvulus, hernia, femoral and inguinal obstruction, amiens, and resulting from cecal distension, gynecological, subphrenic, and genitourinary are also subpubic, suprapubic, and extraperitoneal abdominal wall hematoma, abscess, and sauce abscess. Okay, so once you cover these causes, like you have to look into the here they're showing left upper quadrant, mostly related to pancreas. GI causes like gastritis, peptic ulcer disease, splenic causes like splenic infarct, infarction, splenomegaly, cardiopulmonary, and genitourinary. Left lower quadrant is GI related like diverticulitis, colon, and proctitis, gynecological, genitourinary, extraperitoneal, right? And then this is also divided into suprapubic, diffuse, and epigastric. Epigastric is mostly related to heart, and MI and pericarditis, gastritis, and GERD, peptic ulcer, miliary waste tear. Suprapubic is mostly related to acute appendicitis, IBD, and gynecological causes are more here. That means ectopic pregnancy, PID, endometriosis, threatened incomplete abortion, hydrocephalus, selphingitis, ovarian torsion, hemorrhagic fibroid, tubo-ovarian abscess, gynecological tumor, genitourinary like cystitis, urinary colic, epididymitis, testicular trojan, acute urinary retention, extraperitoneal causes like rectal sheet, hematoma. So this would present with the sudden onset of pain with swelling. Diffuse pain like peritonitis, acute early appendicitis, perforated appendicitis, mesenteric ischemia, gastroenteritis, colitis, constipation, bowel obstruction, pancreatitis, IBD, IBS, Ogilvy syndrome, cardiovascular like aortic dissection, ruptured aneurysm, sickle cell crisis, perforated ectopic pregnancy, PID, urinary retention, carcinoid syndrome, DKA, Edosonian's crisis, hypercalcemia, lead poisoning, and tertiary syphilis. So the reason for reading all these causes is at times we do listen to these diagnoses and we do have them in the mind. So it's just to have an overview of what are the causes. Okay. So now going on to the boxes on the right side. So like now that GS has different causes, and gastroenterology has different causes. So the ones mentioned here, if you even you learn this should be good. So make sure you learn each and everything that I've just you should have a clear concept at least. Okay. So let's say if each quadrant is considered, you should have at least 4 to 5 diagnoses in your mind, minimal. Okay. In all patients presenting with acute abdomen, order the following key tests for specific diagnosis: ALP, ALT, and AST bilirubin. So this is liver enzymes with bilirubin, lipase amylase to rule out pancreatitis, urine analysis to rule out urinary tract infections, beta HCG in women with childbearing age, very very important. So if you even get any questions regarding women, make sure if she's a fertile in her fertile ages, make sure to mention beta HCG first. Troponins, lactate. The key test for OR preparation is CBC electrolytes, creatinine, glucose, INR, PTT, chest X-ray if history of cardiac or pulmonary disease, ECG if clinically indicated by history or if more than 69 years old or no risk factors. No risk factors or more than 69 or is clinically indicated. So you'll do ECG, you have to do a chest X-ray if there's a cardiac pulmonary condition, and these are the baselines that you have to do. Choosing wisely does not recommend routine preoperative blood work for ambulatory elective surgery. So if it's an elective surgery, healthy patients, you don't have to do all the preparatory preoperative blood work. Types of peritonitis: primary, secondary, and tertiary. Primary is spontaneous without clear etiology due to perforated viscous is secondary. Tertiary is recurrent secondary peritonitis, more often with resistant organism. So recurrent secondary is tertiary, and if there's a perforation of the viscous, that is secondary, and spontaneous peritonitis without any cause, that is primary. Localization of the pain: most digestive tract pain is perceived in the midline because of the bilateral symmetric innervations. Kidney, ureter, ovary somatically innervated structures are more likely to cause lateralized pain. Parietal peritoneum is the one that is covering from outside, supplied by somatic sensory nerves of body wall. Pain is sharp and well localized. So we have learned previously in gastroenterology as well that parietal pain is sharp and localized, whereas visceral pain is supplied by autonomic sensory nerve. So pain is colicky and poorly localized. Referred pain: biliary colic to right shoulder or scapula, renal colic to the groin, appendicitis periumbilical to right lower quadrant, pancreatitis to the back, ruptured aneurysm to back or flank, perforated ulcer to the right lower quadrant, right paracolic gutter, hip pain to groin, and ovarian torsion to flank and groin. Okay. Most common presentation of surgical pain: sudden onset with rigid abdomen, perforated viscous. Pain out of proportion to physical finding, ischemic bowel. Vague pain that subsequently localizes appendicitis or other intra-abdominal processes that irritates the parietal peritoneum. Waves of colicky pain, bowel obstruction. This box I find it very important. Why? Because in questions at times they give you these statements: that sudden onset of pain with rigid abdomen. The let's say 50-year-old female patients came to ER with sudden onset of pain since past 2 hours. On physical examination, the abdomen is rigid with is rigid and tender. So what is your initial diagnosis, or they might ask you for differentials or initial most likely diagnosis. So that is going to be perforated viscous. So you need to emphasize on these words. If it's a certain pain, if it's rigid abdomen, then this is perforated viscous. Pain out of proportion: this word specifically is used for one another thing. If you can recall, we use this for there was this condition after orthopedic surgery that we do, and in that condition we have to do decompression. What is that condition called? uh, Compression. Yeah, there's a pressure built up in the leg. I cannot recall exactly the word of that situation. If you guys can, please comment down below, because that's actually pain out of proportion is one of the very classical sentence used for that condition. And then this is ischemic bowel as well. So two things to remember on that. The one that I am forgetting, and the other one is ischemic bowel. Vague pain that subsequently localizes is appendicitis or other intra-abdominal process that irritates the parietal peritoneum. Waves of colicky pain, which says bowel obstruction. Now, acute abdominal mnemonic. Abdominal is the mnemonic where it's up to you if you guys want to remember that mnemonic. So you want to keep it to the quadrant. A for appendicitis, B for biliary tract, D for diverticulitis, ovarian disease, malignancy, intestinal obstruction, nephritic syndrome, acute pancreatitis, liquor, and ethanol. So yeah, we're done with the abdominal pain differentials on general surgery as well. So now we have to cover it from ER as well. So let me just quickly open ER medicine, and then we'll figure it out if there's an additional thing that we need to learn from ER medicine. Seizures, headache, chest pain, pelvic pain, abdominal pain. So common approach to common ED presentation. Now this is ER 18. So you need to remember that abdominal pain will be covered from 4 different sides: family medicine, gastroenterology, general surgery, emergency medicine. Okay. And now I'm spontaneously, like I'm telling you constantly the important stuff to remember and what not to remember. Okay. So this is not a big one. This is just that is it. Okay. Select differential diagnosis of abdominal pain. So much repetition. You see, GI, perforated viscous bowel obstruction. Perforated viscous, what did I tell you? Tender, rigid abdomen, right? With sudden onset of pain. Bowel obstruction, vague abdominal pain. Ischemic, sudden onset of pain. And appendicitis, right upper quadrant, dull pain. Strangulated hernia, sudden onset of sharp pain. IBD flare, esophageal rupture, peptic ulcer disease. Less emergent are diverticulitis, gastroenteritis, GERD, esophagitis, gastritis, and IBS. Hepatobiliary, hepatic splenic injury, pancreatitis, cholangitis, spontaneous bacterial peritonitis. Genitals are female ovarian torsion, ectopic pregnancy, tubo-ovarian abscess, male is testicular torsion. Urinary is pyelonephritis, CVS is MI, aortic dissection, abdominal aortic aneurysm. Respiratory, the most emergent ones are pulmonary embolism, empyema, metabolics, DKA, sickle cell crisis, toxins, adenosonian crisis, significant trauma, acute angle closure, glaucoma, and other. Okay. And the less important one are herpes zoster, psychiatric abscess, hernia, mesenteric adenitis, toxic ingestions, and lead poisoning as well. Okay. So what you need to remember is that most emergent situation are the most important ones. You need to remember these. They want to check if you are a safe doctor. By safe doctor, I mean to say that if a patient is coming with, let's say, abdominal pain, and he's a, let's say, for a 55-year-old male, they want to check if you can think about MI, aortic dissection, abdominal aortic aneurysm, pulmonary embolism, empyema, because these are life-threatening conditions. So you need to think about emergent situation first, and then you need to think about less emergent ones. Okay. If a patient is coming in with abdominal pain, you need to think if it's related to heart, if it's related to GI tract, if it's related to kidneys, if it's related to pancreas. So that's where they check you as a doctor, that if you are competent enough to pick those situations up and address it accordingly. Differentials can be focused or anatomically by location: pain, right upper quadrant, left upper quadrant. So that's the picture that I showed you. So that's how you focus, check the differentials. And then history wise, you'll ask OPQRST, that is onset, onset, position, quality, radiations, severity, and timings. So this is OPQRST. This is mnemonic. Even this part is very important for NACOSCI as well. Okay, so in NACOSCI, if you're preparing for that, you can cover this for NACOSCI as well. Review symptoms from genital, urinary, gynecological, GI, respiratory, cardiovascular symptoms. Abdominal trauma, surgeries, most recent colonoscopy, most recent endoscopy, last FOBT or FIT test. Okay, so you need to rule these things out. Most important thing is OPQRST of the pain, and then review of the symptoms, and then also the last colonoscopy, last FIT test, and most recent endoscopy. Vital signs, you will take vital signs, you'll check abdominal, you'll check for DRE, CVA tenderness, and then you will check for pelvic genital respiratory. So you'll do an appropriate examination, right? Investigations, ABC, airway, breathing, circulation. Do not delay management consultation if patient is unstable. So you have to stabilize the patient first, ABC, and then you have to do labs, CBC, electrolyte, glucose, blood urea nitrogen, UCEs, liver enzymes, LFTs, lipase, beta HCG. Never forget beta HCG for a fertile woman, ECG, troponins, VBG, lactate. Abdominal X-ray if suspicions for foreign body or small bowel obstruction. Air fluid levels would be shown on obstruction. In low resource setting, can also use a frequent SBO or usual conservative management. So if you are in a low resource setup, you have to think about doing abdominal X-ray. Okay, chest X-ray upright, look for a pneumoperitoneum, free air under the diaphragm. That would show that there is a perforation of the viscus. Ultrasound, organological structures, testicles, bilateral tract, biliary tract, ectopic appendicitis in children, young children, nephrolithiasis in young patients. Abdominal aortic aneurysm, free fluid in selected patients can proceed to CT if ultrasound of non-diagnostic, but there is high clinical suspicion. So if there is a high clinical suspicion, ultrasound is not diagnosing it, so you go for CT. CT is usually done for small bowel obstruction, trauma, abdominal aortic aneurysm, pancreatitis, nephrolithiasis, appendicitis, diverticulitis. Mostly gut symptoms, appendix symptoms, stones, pancreas, and trauma in aortic, abdominal aortic aneurysm and small bowel obstruction. You do small CT scan. Management, NPO, IV, NG tube. So you'll keep the patient, you'll ask the patient to fast, and then you'll give him IV hydration. You'll put NG tube for decompression if small bowel obstruction. You'll provide patient with analgesia and consider antibiotics, antiemetics. Growing evidence that small amount of opioid analgesics improve diagnostic accuracy for physical examination of surgical abdomen. Consult as necessary internal medicine, GS, vascular surgery, depending on the cause. Disposition, admission, surgical abdomen, workup of significant abdominal findings. Need for IV antibiotics, pain control, discharge patient with negative labs and imaging workup who improve clinically during their stay. Instruct the patient to return if the severe pain, fever, persistent vomiting. So when to discharge and when to admit. So this is the disposition that you need to know. When to admit, surgical abdomen, workup for significant abnormal findings and need for IV antibiotics or pain control. Discharge when everything is negative and the patient is improving, and just do safety netting, let him know about severe pain, fever, and persistent vomiting, then he needs to return. So pelvic pain will be covered in another section where gynecological conditions are considered, because in pelvic pain you mostly consider the gynecological conditions you can see here. So now I have covered abdominal pain from 4 different chapters. One is family medicine, one is emergency medicine, one is family
NOPQRST, ASOC.
sorry. So we'll go ahead and look at this. Let me see. Okay, so this is the abdominal pain, chronic abdominal pain, acute abdominal pain. Now if you go back to the objective, you will find out that this is what they require you to do. So make sure you cover abdominal pain from 4 different chapters. One is emergency, second is family medicine, third is family medicine, emergency medicine, gastroenterology, and general surgery. 4 topics. Okay, so your 2 to 3 objectives would be covered. Okay, so thank you for watching this video. I hope you like it. Please do subscribe to my channel. Comment down below if you guys specifically want me to make videos on something specific. So that should be it. Please make sure to subscribe and like this video. Thank you.